Okay, so today we're going to start talking about the lymphatic and the immune system. And we said that, our body contains 10 times more microbial organisms than our own cells. Some of them are living in a symbiotic relationship. What's symbiotic? Symbiosis. Symbiotic means both are benefiting. So like the bacteria who live in our intestine, they fight off any other bacteria that try to colonize our intestine, and to ensure that nobody else compete and take the resources besides them. In doing so, they protect us. So they are fighting other bacteria on our behalf. And we said that the immune system is not an organ system, but it's a network. It's a cell population that inhibits all the organs and defends the body from any agents of the disease. So we talked about one of the first main functions of the lymphatic system. We said that it's supporting and working with the venous side of the circulation to restore any fluid that lags behind. So how much fluid is successfully returned to the venous circulation from the tissue thanks to osmotic pressure? How much? I'm sorry? How much fluid is returned from the tissue to the venous side of the capillary circulation thanks to the osmotic pressure? 85%. And how much lags behind that thanks to the lymphatic system we're able to return it back? 15%. That's the first job. The second job is the lymphocytes, the B lymphocytes, the T lymphocytes. So they are residing in the lymph nodes and they activate a protective immune response. And lastly, we said, what do the lacteals? The lacteals are responsible for, where do we find the lacteals in our body? The small intestine. And what's their job? To reabsorb dietary lipids. Very good. Okay, so that shows you here that this is the lymphatic system is always supporting the green side of the circulation, and these are the lacteals that are helping the small intestine. We said the lymph is that 15% recovered fluid, and we have lymphatic vessels. These are responsible for transporting the lymph, and there are tissues, aggregates of tissues that are composed of lymphocytes and macrophages that populate many organs in the body. Lymphatic organs, these are defense cells. We said, what's the biggest example of a lymphatic organ? What's the biggest example of a lymphatic organ? The spleen. That's a big example of a lymphatic organ. Also the liver. That's another example of a lymphatic organ. So we said that the lymph is a colorless fluid similar to plasma, but it has much less protein. So that point is very, very important to know. And the lymphatic capillaries, they are found on every tissue, because every tissue that needs blood is going to need a venous circulation. That's going to need the lymphatic system to help the venous circulation restore all of the excessive fluid. So here, this is an excellent demonstration. It shows you here that the lymphatic green capillaries are surrounding the venous side, and they are taking all of, and you see behind, these are your tissues. So the tissue is constantly breathing. From the red side of the capillary circulation, the arrow is pointing out. So we're getting oxygen. And on the green side, you have the arrow is pointing inwardly. What is that? That is a lymphatic vessel. You see, the lymphatic vessel is always surrounding the tissue. So the tissue is going to send out all of its carbon dioxide, all of its metabolic waste to go through these openings, and from the openings, we're going to travel through the lymphatic vessel back into the right heart. What you also need to know is, how does the this sewage system, how does the lymphatic system return this lymph fluid to? Because it's no longer a dispute that the lymphatic fluid goes back into the right part, not the left part, the blue part, not the left part. But where exactly? Obviously, the vena cava, because who enters the right side of the heart? The superior vena cava and inferior vena cava. So where does the lymphatic fluid gets dumped? In the vena cavas? No, the vena cavas enter the heart. The lymphatic fluid enters into the subclavian vein. That's very important. Then the subclavian vein delivers it to the vena cava. So the lymph fluid doesn't go to the vena cava directly. It goes to a station before that, and that is the subclavian vein. No artery. We don't deal with arteries in the lymphatic, always veins. Okay, and as you see here, the lymphatic vessel has a tunica interna, a tunica media, and a tunica externa. So that shows you in the embryological development, the lymphatic vessels grow out from the semi-embryonic layer as who? As the lymphatic vessels, as the blood vessels. The blood vessels have tunica interna, tunica media, and tunica externa. So do the lymphatic vessels have tunica interna, tunica media, tunica externa. They converge into larger and larger vessels. So the collecting vessels course through many lymph nodes. Okay, so that shows you the valves. That what's the point of the valve is to ensure that the lymph flow is only in one direction. We don't have a reflux of lymph fluid that goes back to the tissue. We want the lymphatic tissue to transport this lymphatic fluid through in one unidirectional way, going back into the subclavian. So when we look at the lymphatic vessels, we see that we have 6 lymphatic trunks. These 6 lymphatic trunks drain the major portions of the body. So we have a jugular, subclavian, and bronchomediastinal. So these are the 6 lymphatic trunks. The jugular is 1, subclavian is 2, bronchomediastinal is 3, the intercostal, intestinal, and the lumbar trunks. These are your 6 lymphatic vessels. Now the vessels empty their lymph into trunk, and the trunks empty their lymph content into ducts, into the ducts. So how many ducts we have? We have 2 ducts. One duct is responsible for receiving the lymph from the right arm and the right side of the head and the thorax, and they empty into the right subclavian vein. So that's a small compared to the thoracic duct. The thoracic duct is much larger and much longer because it receives the lymphatic drainage from all of the remaining parts of the body. And it contains the cisterna chyli. You must remember that. Where do we find the cisterna chyli? Do we find a cisterna chyli in the right lymphatic duct, or do we find a cisterna chyli in a thoracic duct? We find it in a thoracic duct. And where does the right lymphatic duct empty its lymph content? In the right subclavian. And the thoracic duct empty its content into the left subclavian. That's very important. So the subclavian veins collect lymph from both ducts. That is very, very, very important. Also, you must remember which of the two ducts is much larger, much bigger, and receives the lymphatic drainage from all of the body. And that is definitely the thoracic duct. Very good. Okay, so here we see the cisterna, that is the cisterna chyli. And you see here, you have this is the lymphatic capillaries and the lymph nodes. They are on the side of the blue side of the circulation. And there's a right lymphatic duct. This is the right subclavian. So you see the right lymphatic duct is going to empty into the right subclavian vein. And there are other nodes, the axillary nodes and the lymphatic vessels of the breast. You must also remember that the lymphatic system is a dangerous access site for the cancer cell. So if the cancer cell is able to access the lymph node, this is one of the assessments of the degree of cancer, what stage the cancer is. If the cancer reaches the lymph node, that's immediately going to go into the very dangerous stages, because now the lymphatic vessel is going to allow for the movement of this cancer cell. This cancer cell is going to lodge. It's going to lodge into the lymphatic vessel, and it's going to go to the lymphatic node, and from there it's going to disseminate. Once it disseminates, all it needs is to latch and attach to any far site. So you can have lung cancer. Once it reaches the axillary node, it's going to go to the brain. It's going to go to the bone. So that's how cancer metastasizes. Cancer invades nearby tissue, but it doesn't metastasize until it goes into a different tissue. We started with bone tissue, we end up in nervous brain tissue. We start with the digestive system cancer, we end up in the bone, we end up in the lung cancer, God forbid. So that's called metastasis. So metastasis needs the lymphatic system. That's why they always remove the lymphatic ducts in order to ensure that cancer does not access. Because once cancer reaches the lymphatic system, is gonna travel all over the body. Okay, so that shows you the drainage of the thorax, and we said that the lymph is a fluid, so it must also obey physics, the biology and the biophysics of fluid movement, and that is fluid, whether liquid fluid or gas fluid, will never move except from from an area of high pressure to low pressure. So that shows you the lymph flows under forces similar to those that govern a venous return. But there is no pump. For the blood, the heart is contracting and pumping the blood. But who's pumping lymph? Lymph is not pumping because lymph is not based on hydrostatic pressure. What pressure is the lymphatic system relying on? Osmotic pressure. Excellent. And we call that colloid osmotic pressure. The lymph is also going to flow at low pressure and slower speeds because obviously the speed of osmosis will never be the speed of a pump. That's hydrostatic pump. And it's going to move along a rhythmic contractions of the lymphatic vessels. So the stretching of the vessel is going to stimulate this contraction. The flow is aided by the skeletal muscle pump. The flow is aided by, so it's the same way our skeletal muscles, we talked about that when we were looking at the cardiovascular system. We said that the blood that is trying to make its way up from the lower limbs to the heart, your skeletal muscles, when they contract, they press, they squeeze and pressure the blood fluid in order to move back into the heart. The same thing, your skeletal muscles are gonna pump this lymph fluid and contract and crush and squeeze these lymphatic vessels in order to propel the lymphatic fluid. The thoracic pump is gonna aid the flow from the abdomen to the thoracic cavity. So now let's talk about the lymphatic cells. Lymphatic cells, students remember T lymphocyte, B lymphocyte, but they forget the NKs. The natural killer cells are lymphatic cells, and these are large lymphocytes. They attack and destroy bacteria, but they work indiscriminately. So people assume that they are not lymphocytes, but they are lymphocytes. The T lymphocytes, they mature in the thymus, and the B lymphocytes, they mature in the bone. I need somebody to remind me, what do we mean when we say the B lymphocytes mature and the T lymphocytes mature? What do we mean by mature? Training, excellent. What kind of training they get? Exactly. What to target, non-self, and what to leave alone, self. So how are they going to get to train to do that is by them memorizing the proteins that are found at the surface. So how are you recognized when you go in your family, when you walk in a house, nobody call the cop on you because they know how you look. They know your hair, your face, they know yourself. But if I walk in the house, they're gonna call the cops on me, they don't know who I am. The same thing. Your immune B cells and T cells are being taught in training in the B marrow and the thymus to, hey, remember, our cell, the protein on the surface of our cells look like that. No two people will ever have the same protein and glycolipid. Remember, we call that the glycocalyx, a collection of proteins and lipids and sugars that are coating the outside extensions of your plasma membrane. That is used for identification, like cell marker. That's your ID. That's your social security number. That's your phone number. Nobody else has it. Except two people get to share the same protein. What will be? Mom and her baby. Twins, but you know that's half credit. That's not full credit. Why? Because you have two kinds of twins: fraternal twins and identical. That's identical. These are the ones they can give each other liver, they can give each other blood, they can give each other anything, and their immune system will never detect it because they have the same galactic habits and the same antigens. They have the same thing, but the variety, yeah, the variation is like a mutation, it's not a mutation. Because both of them, they had the same sperm fertilizing the same egg, but the egg split in half. It's not like two sperms fertilizing two eggs and you have two placenta. No, they had the same egg split in half. So they share the placenta, they share everything.
So are they only contingent on if the mom has twins on her side? Or twins completely random, it doesn't matter if it's the dad's side or the mom's side.
What do you mean?
Like, should I have like the twin come into like a twin running my family? Does that mean that would have to be on the other side?
I don't think it's hereditary. I think it's random chance. It's just random. Nobody's God. Nobody knows what else. But the more you try, the more chance you can get it.
That's true.
If you're gonna have a football team, you gotta fit me.
My friend's mother and father had three sons.
Wow.
Back to back.
All identical?
All I and I was like,
Wow. She had three sets of twins back to back. Were they boys?
two sets for girls, one for boys.
If they were all boys, then maybe she had a sister, you tell me. Right? I'm trying to have many kids. Anyways, but yeah, it's random. So that's rare. The biology is very confusing. We don't know. But yeah, it's very confusing. Some woman, she had a septet, like 6 kids. Oh my God, if I had that, I will retire from having children. Just 6 and done. They can be a whole A&P class by themselves. They go to the same school. They have a summer class, 6 of them. That's it. So yeah, the way we train is to remember, make the body. This is why when you have juvenile diabetes, you have autoimmune disease. In autoimmune disease, your own immune system destroy your own pancreas. Your own immune system destroy your own cartilage of the rheumatoid of your knees. Why? Because they forgot the training. They can no longer tell self from non-self. Okay? And now they are hoping to make the immune system recognize cancer cell as non-self. Because cancer cells have some glycoproteins that are not part of self. But the immune system is not see details, doesn't have the high specificity. So now we're trying to waking up women, they see more better detail than men. My grandma, we were watching a wedding, and I said, "Do you see that girl?" She said, "The one who had the necklace." I could have never seen I could have never noticed that. So now your immune system is the cancer cell and your own cell, they are similar. But the cancer cell has like a necklace or something that your cell doesn't have. But your immune system, the training, it can barely remember its own cells. Your immune system is destroying your own knees, let alone remembering the difference between cancer and you. So now we're trying to waken up the immune system, trying to make it remember, to see the details, the very tiny details. Okay. Yeah, my grandmother. Yeah, I zell her $2,000. She was happy. She in my country, she was so happy. She said I'm her favorite grandchild.
How much is it in your country?
Is a lot. Is a lot. Yeah, she was happy. I said all my grandmoms money. Yeah, so macrophages. So macrophages, these are also lymphatic cells, but macrophages, they are, the cells kill in different ways. Some cells kill you by swallowing you, galloping you. That's the macrophage. The macrophage will swallow you. The B lymphocyte, it will throw antibodies at you. Antibodies, Y-shaped antibodies to kill you. The T cells will not swallow you, will not throw Y-shaped antibodies at you. They will throw enzymes that make whole, like perforin, perforin enzymes. So when you make holes, water is going to flow inside the bacteria is going to blow up. They put granzymes, they're going to hydrolyze. So they use enzymes. It's very important to know that. Macrophage, swallowing. B lymphocytes throw Y-shaped antibodies, like bullets to kill you. And T lymphocytes, they throw granzymes, perforins, and they throw enzymes, hydrolytic enzymes, metalloproteases, acids, degradative enzymes, so they rely on enzymes to destroy and kill. Okay? Okay. There's antigen presenting cells. Okay, so now this is really important. Antigen presenting cell. You see these antigen presenting cells. Those lymphocytes themselves, they do not, like let's say this is bacteria. I am a B lymphocyte. I am a T lymphocyte. I can't recognize bacteria on myself. There is some mediator. It's called APC, antigen presenting cell. This mediator, the antigen presenting cell, is gonna, oops, that's bacteria, is gonna catch it, then it's gonna take a fragment off of it. It's gonna branch off, cleave a fragment off of it, and then hold it up, present it. What I call an antigen presenting cell. When they present it, then these guys come. Say, oh my God, the APC cell has something is presented. Let's go find out what it is. Then when they see it, then they destroy it. The antigen presenting cell with the bacteria that it is very important to know that. The antigen presenting cell is a mediator that's gonna awaken your immune cells. They're gonna present a fragment and hold it up. A fragment is gonna contain a protein of that bacteria, a glycoprotein of that parasite, a carbohydrate of that particular parasite. So your B cells, your T cells are gonna come with their training because they already have a training. So they gotta put that protein that is being presented by the antigen presenting cell in the middle. If it fits, it means self. They're gonna leave it alone. If it doesn't fit, you know, they say if it doesn't fit, you must quit. But here, if it doesn't fit, you must get killed. So if it doesn't fit, it means you're not self. That's how they scan. So the B cells, they go to all the antigen presenting cells. Antigen presenting cells, they go to your cell, lift up some protein, your lymphocytes scan it, it fit, leave it alone. That's self. But when they scan some antigen presenting cells with carbohydrates from bacteria or even from transplanted liver, it's not gonna fit. They're gonna destroy it. So it's the antigen presenting cell. That is the one that your B cell, T cell rely on to tell if this is self or not self. Are we clear? So that shows you, this is the bacteria and these are the macrophages coming to destroy it. We also have dendritic cells. Dendritic cells, these are also immune cells, but they are mobile. They are antigen presenting cells. So the dendritic cells, these antigen presenting cells, themselves, they fight the bacteria. Sometimes they kill it, sometimes they ask for extra help. So the dendritic cells are found in the epidermis. When you do the did you guys do the integument? The skin. You should have done that last semester. Integument. So when you do the integument, you should have seen that on the bottom of your dermis layer, there's like dendrites, many dendrites that are scanning because as we said, your skin is the first line of defense that is gonna trap a lot of bacteria. So the dendrites are gonna come in and destroy and present antigen presenting cells. We said antigen presenting cell. Wouldn't it describe what antigen is? Students have a problem. Antigen, antibody, immunoglobulin, what is that? Antibody is the weapon, is the Y-shaped weapon, bullet we're gonna fire to kill. Antibody, we kill with antibody. Antigen is that thing we use to present. It could be a protein, it could be a sugar, it could be a lipid. It has to be part of your ID. That's who you are. So there is self-antigen, there is non-self antigen. So antigen is not a good or a bad thing, depending on who you are. Antigen is a part of you. So your antigen is your glycoproteins, your sugars, your lipids, your carbohydrates. The bacteria antigens, these are known foreign antigens. They are self-antigen and foreign antigen. In the training, the B cells and T cells are being trained to detect self-antigen and leave them alone, and detect non-self foreign antigen and kill them. Are we clear? Okay. There's also reticular cells. These are stationary cells that contribute to the stroma. What's stroma? There's stroma and parenchyma. Parenchyma is the actual tissue of the system. Like the neurons or the parenchyma of your brain, the cardiac myocytes, parenchyma of your heart, and your endothelial cells or the parenchyma of your blood vessels. But no system exists solely only on parenchyma. We need stroma. So the stroma is the connective tissue. These are the supportive tissue. So in the classroom, we don't only have a whiteboard and chairs. We have lighting, we have extra supportive stuff that is not basically bad, like it's not basically there's other classrooms, other colleges in other countries, they have a whiteboard, they can even have a blackboard and chalk and chairs. The chairs are practical, it's very important. And the whiteboard is very important. But the projector, all that's supported. So the same thing, every system has parenchyma and has stroma. These are reticular cells, they are protecting because you know if you want to be doing immune surveillance, you have to protect both the parenchyma and the stroma. You cannot say, well, I'm only concerned about the well-being of my parenchyma in the system. No, what about the stroma too? Because if the bacteria or a microbe get into the stroma, they can leak into the parenchyma. So we do immune surveillance in both. Is that clear? This MALT is very important, mucosa-associated lymphatic tissue. You know, we are hollow from inside our esophagus. You know, some people have lactose intolerance, so they have diarrhea. The milk, they had diarrhea and never entered their body. Even though it was in, it never entered your body. So if you're on the outside or you're on the inside, you're still on the outside until you make it to the blood, until you get absorbed from the intestine into the blood. Now we say you in the body. Well, when you take a tablet, you take a pill, 85% of the pill gets broken down by your digestive system enzymes. 15% get absorbed. So 15% is inside your body, about 85% is going to get destroyed. Even though both were in. So once you're in, it doesn't mean you're in. So that's why your digestive system has a lot of bacteria. We said there's a lot of bacteria, a lot of, you're eating all of this H. pylori, all of this food, this disgusting, this pollute processed food. So your immune system is having a lot of mucosa-associated lymphocytes. So that there's mucosa in your esophagus, there's mucosa in your stomach, there's mucosa in your intestine, there's mucosa in your large intestine, there's mucosa in the anal and the renal and the rectal canal. So that is a site of dangerous access. So it is rich in lymphocytes. All of the lymphocytes that occupy the mucosa are known as MALT. M-A-L-T, mucosa-associated lymphatic tissue. So we talked about the lymphatic nodules. These are dense aggregates. And we have primary lymphatic organs. And we said that the bone marrow is where we have the red blood cells and the white blood cells and the primary lymphatic organs. These are cells that are born and mature in this bone marrow. So the red bone marrow and the thymus, that's where the main initial development of the lymphocytes takes place. It's the site where the T and the B cells become immunocompetent, and they are able to recognize and respond to the antigens. The secondary lymphatic organs, they are mature cells and they are located in lymph nodes, tonsils, and in the spleen. So these are immunocompetent. So immunocompetent means what? It means you made it through the training. It means you made it through the training and now you are ready to fight. The red bone marrow is involved in hemopoiesis, and it is a soft, loosely organized, and highly vascular material. Okay, so that shows you the sinusoids of the bone, and the bone has yellow marrow and red bone marrow, and there are many white blood cells that are ensuring there is no infiltration of microbes. The thymus. So the thymus is very big in children, but by the age of 14, it becomes really tiny. That's known as involution. So involution, there are two glands in your body that begin very big, but they become really tiny. They begin very big and they end up really tiny. The first one is the thymus. That's why the elderly have a really small thymus. So now when we get older, our T cells can no longer mature because our thymus got too small. So no many T cells are graduating. That's why when we get older, we get this T cell, all of this is a rheumatic disease when your immune system is destroying the cartilage. Who's doing that? The T cells. Because the thymus got so small, they're not growing anymore. So now they don't get trained properly. So now they don't know stuff from not stuff. What's the other gland that begins very big and then gets smaller with time? Pineal gland. But that's why the babies sleep a lot, because they have a huge pineal gland. But when they get old, about 15, it gets really small. It gets really tiny. Are we clear? So remember the thymus. And where is it? It's like on the mediastinum, exactly where a necklace would be. So if you wear a necklace, exactly where the necklace would end up, that is your thymus. So that's the thymus. And talked about the lymph nodes. Oh, this is very important too. What's the difference between afferent lymphatic vessel and efferent? Afferent meaning you are bringing the lymph into the lymph node. And efferent, it means that you are about to leave the lymphatic node. If you take a sample of fluid in the afferent lymphatic vessel, meaning you're about to enter into the lymphatic node, then you take another comparative fluid on the other side in the efferent lymphatic vessel, and you compare both. What do you think is going to be the difference? A sample of lymph fluid that is about to enter the lymphatic capillary and a fluid that already graduated and went on the other side, the efferent, the hyaline. What is going to be the difference? What is inside the lymph node? What's happening in the lymph node? Filtration, immune activity. So the fluid leaving the node is going to have less bacteria, it's going to have less microbes, it's going to have less toxins. Is that clear? Do you know which one is afferent, which one is efferent, what is the significance? Are we clear? There we go. So now you see the arrow is pointing in, pointing in, pointing inward, pointing into the node. Is that efferent or afferent? That's afferent. And leaving the node, is that efferent or afferent? That's efferent. Very good. So these are the types of the lymph nodes: the cervical lymph nodes, the axillary lymph node, the thoracic lymph nodes. There's abdominal lymph node, intestinal and mesenteric lymph nodes. Then there's the inguinal and popliteal lymph nodes. That is your inguinal lymph node. We talked about those, lymphadenitis and lymphadenopathy. What is lymphadenitis? Yeah, which indicates there's what? It indicates there's inflammation that we have trapped. We successfully trapped something we are fighting, and that thing is fighting hard. That's why there's a big fight, there's big edema, and there's inflammation. Okay, the lymphadenopathy is the generalized term for all the lymph node diseases. So lymphadenitis is part of lymphadenopathy, but not every lymphadenopathy is lymphadenitis. So the lymph node can be inflamed, it can have cancer. Cancer is not inflammation. It can have cancer, it can have edema. So the more safe word to use is lymphadenopathy, but it's very general. But to be very specific, it's lymphadenitis. Lymphadenitis. Metastasis, we discussed that. Metastasis is the cancerous cell lodging, breaking off from the original site and then traveling to a far distal side. The tonsils, you have the pharyngeal tonsils. We have the lingual tonsils in the mouth, the roof of the mouth, the pharyngeal tonsils. And these are aggregates of very dense patches of lymphatic tissue that are located at the entrance of the pharynx. So they guard against ingested or inhaled pathogens, and they are covered with epithelium, and they have deep pits or tonsillar crypts. These are lined with lymphatic nodules. So the removal of the tonsils due to severe irreversible inflammation, this tonsillitis, is known as tonsillectomy, cutting of the removal of the tonsil. But this is obsolete, no longer being done, because many cases are not very strong. So they can reverse this tonsillitis. Back in the day, it was really very hard, so they just removed it. It was as recent as, I believe, 15 years ago? Yeah, 15 years ago, they used to have tonsillectomy. But now,
We still get it from a hospital, the summer, probably.
yeah, they still do it?
Yeah.
Yeah, but it's rare. You work where?
I work with doctors, they work. I work in
Histology.
Yeah.
Histology, yeah, that's very nice, yeah. Yeah, very good. So you guys take tissues of removed tonsils, I see. So maybe they do have the tonsillectomy, but it wasn't done because of tonsillitis. So
So basically, some patients have the inflammation, the inflammation damages the.
yeah.
Because we get the specimen from, and then we process.
Yeah. So back in the day, it was very, very like, you just go, you have something in the tonsil, they just remove it. But now the medications are more effective, but it actually does happen. It does happen. But you're right, because they are so sensitive, sometimes inflammation destroys them irreversibly. Grow back because they are there and now they are gone. They remove the entire stem cell. So it's not like they remove the region. Back when we were young, I had a friend, he said that he wishes that he gets a tonsillectomy. So I said, why? He said, they give you ice cream afterwards. I come from a very impoverished country. So these are, I don't know. So this is what happened back in the day. He said there is nothing in life that he wishes more than having a tonsillectomy. Because his friend had a tonsillectomy and he was given ice cream afterwards. Is that true? Okay. We are guys. We are guys. Judge Judy says to her, the people in the court, says, listen, I know you're a guy. But work with me. Work with me. But something like that, it's just nobody can say it, but she just gets everything. Anyway, that's funny. But yeah, Tom, this reminded me of my friend. He's a pharmacist now. Yeah, things turned around. So these are the tonsils we have. Palatine tonsil in the mouth, lingual tonsils. These are at the root of the tongue. Palatine is at the roof of the mouth. And the pharyngeal tonsils, these are the adenoids. These are the single tonsils of the wall of the nasopharynx. So a question would be, which of all the tonsils is not paired? So the lingual tonsils are paired. The palatine tonsils are paired. And who is not paired? The pharyngeal. So that's the pharyngeal tonsil. That's the palate. That's the pharyngeal tonsil. That's the palatine tonsil. And this is the lingual tonsil. The spleen. So the spleen is the largest lymphatic organ. The spleen is also known as the graveyard of what? Red blood cells. So it is, you know the show American Ninja Warriors, where you have to like do some tricks, and that's exactly what the spleen is all about for red blood cells. So there's sinusoids, tiny, very blood-filled sacs that are like a test to see the durability of the red blood cells, to see if they can maneuver excellently and properly. If they can make it through, they survive. If they cannot, they get too old, they get destroyed. Okay? And we said that the spleen has a red pulp. These are sinuses filled with erythrocytes, and there's a white pulp. And this is the lymphocytes, the macrophages surrounding the small branches of the splenic artery. We already talked about the stroma, and we identified that the parenchyma is the functional central tissue of an organ. That is distinguished from the connective and supportive tissue known as what? No, the parenchyma is the functional tissue. The connective and supportive tissue is known as the stroma. Stroma. Remember we discussed that, that's the stroma. So the spleen is where we scan for red blood cells, and we talked about this spleen being the graveyard. The white pulp, rich in white blood cells, monitors the blood for foreign antigens and keeps an army of monocytes for release when needed. And they stabilize the blood volume through plasma transfers to the lymphatic system. Okay. Ruptured spleen requires splenectomy, but this leaves the person susceptible to future infections and premature death. Okay. Okay, so now we're going to talk about what kinds of immunity we have. This is very important. I think this is the most important slide of the entire lecture. In that innate immunity is part, but it's not the entire part. So remember we said that there are 3 lines of defenses against the pathogens. Pathogens mean pathogenic, causing disease. So the 3 lines of defenses against the pathogen. The first line of defense is the mechanical barrier, the skin and mucous membranes. These mechanical barriers have dermatitis, they have acid, this fluid that if a bacteria touches it or if a parasite touches it, it's gonna destroy it and burn it down. The second line of defense is several innate defenses. You have the leukocytes and the macrophages, antimicrobial proteins, and natural killer cells, inflammation and fever. So that is, if you make it across the first line of defense, the second line of defense is gonna be there are gonna be several innate defense mechanisms. These are the leukocytes and the macrophages, antimicrobial proteins, natural killer cell, inflammation, and fever. The third line of defense is the adaptive immunity. So the adaptive immunity defeats a pathogen and leaves the body with a memory. So now this memory is very important because you will learn that one of the best ways for us to understand the infection a patient is dealing with, take a tiger. A tiger is the blood level of a particular white blood cell. And we're going to look at the immunoglobulins. So the immunoglobulins are the building blocks of the antibodies. So the third line of defense is special in the sense that it is the most sophisticated and the most specific and the most specialized. And that one is going to require the B lymphocytes and the T lymphocytes. So your body relies on inanimate mechanisms like your skin, like your chemical and mechanical barriers. Then you have the inflammation, and the inflammation is redness. It has the 5 cardinal signs: redness, heat, pain, swelling, and loss of function. And you have a third line of defense, and that's going to come after the infection takes place. And that's going to defeat the pathogen and leave the body with a particular memory of. So innate defenses guard equally against a broad range of pathogens, and they lack the capacity to remember. So there is no memory involved except when we're dealing with adaptive. So memory doesn't come except here, when the body must develop a separate immunity to each pathogen. So these are the external barriers. We said that the skin has dermacidins, it has an acid mantle. This acid mantle is a thin film of lactic and fatty acids from sweat and sebum that inhibit the bacterial growth. There's dermacidins, defensins, and cathelicidins. These are peptides in the skin that kill the microbes. The mucous membranes, these are digestive, respiratory, urinary, and reproductive tracts that are open to the exterior and are protected by mucous membrane. So the mucus physically traps, it's like a mouse trap, like a glue. It's gonna physically trap all of the bacteria or the microbes that are gonna enter into the bodily system. Phagocytes, these are cells that engulf foreign matter. And there are 5 types of leukocytes: neutrophils, eosinophils, basophils, monocytes, lymphocytes. We have the T lymphocytes and the B lymphocytes. So you must remember that the neutrophils, these are specialized in killing the bacteria, specialized in destroying the bacteria. And monocytes emigrate from the blood. So monocytes, they grow up. So monocytes are circulating as inactive. But once they find a particular pathogen, they differentiate and grow. So monocytes later become macrophages. Remember the Pokemon? The Pokemon used to evolve, right? So the same thing, monocytes are circulating. Once they see bacteria, once they see parasites, once they see a microbe, they evolve and they become macrophages. That's very important to know. They are wandering around. That's known as immunosurveillance. Immunosurveillance. So if you look here, you have resident sentinel macrophages that engulf the pathogen and release pro-inflammatory chemotactic cytokines. And then the leukocytes squeeze between the cells of the capillary wall as they follow the chemical signals to where they're most concentrated. And then within the damaged tissue, the neutrophils are going to release chemicals that break apart the pathogens, and the monocytes are going to differentiate into macrophages, neutrophils, and the macrophages phagocytize the pathogens and the cellular debris. Eosinophils, they stain red because they are acidic. And they are, so who are the neutrophils going to target mainly? Neutrophils are specialized to kill what kind of microbes? Bacteria. Eosinophils are specialized to destroy and kill what kind of bacteria? Parasites and allergens. Very good. And the basophils, they cause degranulation. They secrete chemicals that aid the mobility of other leukocytes, and they induce chemotaxis. So they activate and attract neutrophils and eosinophils, and they secrete histamine, which is a vasodilator, which increases the blood flow, and they speed the delivery of the leukocytes to the area. Heparin. Heparin is an anticoagulant. It makes the blood flow smoothly. So you should make an inference that heparin is actually supportive to the inflammation. Because what happens in inflammation? There is a fight. So the body needs white blood cells. Imagine the blood was hypercoagulable and thick. It's not gonna, the white blood cells are not gonna get there in time. So you need to make the blood thin, not thick. So it makes sense that during inflammation, these white blood cells, namely the basophils, are going to be secreting a blood thinner heparin, not something that is going to cause a thrombus, like thrombin. So it served our purpose best as white blood cells to secrete heparin, a blood thinner, than to secrete the thrombin. Mast cells also secrete these substances. So these are a type of connective tissue cells that are very similar to the basophils. But there's the concept of the degranulation. So degranulation is to secrete these leukotrienes that are going to induce this they're going to induce this very important destruction of the and recruitment to the inflammation site and destruction of the microbes. So the blood circulation has about 80% T cells, 15% B cells, and 5% natural killer cells. And they have many diverse functions. So the natural killer cells are part of the innate immunity, and all others are part of the adaptive immunity. So there are helper T cells that function in both. So we're going to talk about helper T cells and cytotoxic T cells. You must remember that antimicrobial proteins are the interferons. Please remember that the interferons are antivirus. So whenever there is a viral attack, you will see the interferons skyrocket. That's a very important thing. Same way you know neutrophils target bacteria, eosinophils target parasites. You must remember that interferons indicate that there is a severe viral infection. And then the complement system, which involves the breakage and the cleavage of enzymes in order to activate them. So you would have a C3 protein enzyme that's inactive. When you cleave it, it becomes C3A, C3B. That means it has been activated. So we will see that now. The interferon secreted cells affected by viruses. There are alternating cells and they protect them from becoming infected. So that shows you the viruses are implicated in the high amount of interferons. The complement system is a group of proteins, 30 or more globular proteins that make powerful contributions to innate immunity and adaptive immunity. The complement system proteins are made by the liver. That's why patients who have cirrhotic liver disease, alcoholic liver disease, have a very bad immunity, because their complement system proteins are no longer being made by the liver because the liver is damaged by irreversible fibrosis. So the activated complement system causes the destruction of the pathogen by inflammation, which is the recruitment of other white blood cells to kill that microbe, immune clearance to properly get rid of and dispose of that microbe, phagocytosis, the swallowing, and cytolysis, perforation, and throwing these perforin enzymes that destroy the microbe. So the mechanisms of action of the complement protein, we said you have the inflammation where you see C3A, it means we're activated. If it was just C3, it means it's inactive. But C3A means that there's an activation. Stimulates the mast cells and the basophils to secrete histamine and other inflammatory chemicals. They activate and attract the neutrophils and macrophages. So they speed up the pathogen destruction in the inflammation. So the immune clearance is based on C3b binding with antigen antibody complexes to the red blood cells. Okay, so now the antibody is going to track any antigen that is non-self and cause it to be marked as a marker that later could be removed. We're gonna look at the membrane attack complex. That is like putting a donut hole on the surface of the bacteria. Remember we mentioned the perforin. Perforin are enzymes that make holes at the surface of the cell. And then the water goes inside the bacteria, causing the bacteria to burst or rupture. So that shows you here the multiple activities of the complement system, because opsonization means tagging, being tagged for destruction. Then there's the activation of the inflammatory response, and that's the opsonization, and then the activation of the complement system that's going to make you see a pore. That's the pore through which water, you see the arrow is pointing to the hole of the pore. Water is going to go inside the pore to cause the cell to burst. That shows you the complement is activated by 3 different mechanisms. The classical pathway is going to produce an antigen antibody complex. That's going to cause C3. You see, you dissociate to C3A and C3B. Now it's activated. If you are stuck at C3, you're inactive. You become C3A or C3B, you become activated. C3A is going to bind to the basophil and the mast cells, and it's going to stimulate neutrophil activity and lead to inflammation. While C3B is going to bind to the antigen antibody complex, and that's going to cause immune clearance, phagocytosis, and cytolysis. This is very important. There's a donut. Remember we talked about the donut? So you see that is the shape of a donut because it makes a hole in the membrane of the microbe, and water is going to go right through that hole. And when water accumulates in the inside, what's going to happen to that microbe? It's going to burst. So you see these complement protein, C6, C7, C8, C9, and then C5b, they're going to make like a donut, and that's known as the MAC, or the membrane attack complex. Natural killer cells, these continually patrol and cause immune surveillance, looking for pathogens. And the natural killer cells, they attack and destroy the bacteria, the transplanted cells. These are self-infected with viruses and cancer cells. Remember the perforin. We said the perforin is going to make the holes through which water is going to enter. And there's granzymes. Granzymes, they're going to go inside and enter through the perforin hole and degrade the enemy cell enzymes. Then the enemy cell is going to die by apoptosis. Then the macrophage is going to come, it's going to gallop and swallow that bacteria. Fever is an abnormal elevation of the blood temperature. And the synonym of the fever is pyrexia, and there's a febrile fever pertaining to this heat. But we are concerned about fever because when your body is too hot, that's going to cause a defect in the enzymes, because enzymes have an optimal temperature at which they operate. But the problem is, we don't want this temperature to continue severely, because that is going to cause convulsion in the brain. Fever is triggered by pathogens that are exogenous, which are produced by bacteria, produced by any organisms that going to cause pyrogens. And then there's the endogenous pyrogens. There's endogenous pyrogens. These include the polypeptides secreted by neutrophils and macrophages. So these raise the hypothalamic set point of the body. So endogenous pyrogens, these are caused to be, the onset for endogenous pyrogens is internal. So whenever there is an infection inside your body, your own macrophages would send pyrogens that increase the temperature and cause fever. But if the pyrogens did not come from your own immune cells and rather came in from an outside the microbe itself, by detecting this microbe sending these glycolipids and cytokines on its own surface, then that's an example of an exogenous pyrogen. Whether endogenous pyrogen, whether exogenous pyrogen, we're going to go through these stages. So your normal body temperature is 37 degrees Celsius. Here you're going to have an infection, and the pyrogen is going to be secreted, and you're going to reach a stage known as the stadium. So the body temperature is going to oscillate around a higher new set point. This higher new set point is going to burn this microbe. And then we're going to end into the defervescence. So the defervescence is to bring down the temperature to the normal range. So temperature, actually, this fever is protective because it causes the burning of the bacteria. You know, they say Listerine, when you put Listerine, it burns your mouth, but you can handle it, bacteria can't. Same thing with the fever. It is pretty annoying, but if you handle it, it's actually going to kill all the microbes. But you should know how to handle the bacteria. You should know how to handle the fever. When you have a fever, don't take the antipyretic, because the antipyretic is gonna try to inhibit the enzymes that cause the fever. But rather put a water pad on your forehead or take a cold shower. There, you're not messing up with the enzymes. You're not taking any medication to stop the fever. So the microbes are being burned. But when you take a cold shower, it's going to prevent you from the adverse effects of the fever. I remember I had a fever, it just wouldn't go down. So I went and I took a cold shower. And immediately, on the shower, when I walked out the shower, I was able to walk better than I was walking. I was walking in drowsy, exhausted, lethargic. But after the cold shower, I felt like I got more strength. So it's always good to have a cold shower when you have a fever. But these antipyretics are just going to prematurely end this stadium phase that is actually supposed to be beneficial to remove. Rye syndrome. What is Rye syndrome? Rye syndrome is a disease that's going to cause brain damage, nausea, vomiting, seizure, coma. When? If you give aspirin to children? No. If you give aspirin to children who have a viral infection. like a chicken pox or a flu. So true or false statement would be never give children who have fever aspirin. That's not true. Never give aspirin to children who have fever because of a viral infection. That one is true. That is going to cause Rye syndrome. They're going to end up with nausea, vomiting, seizure, and coma. Inflammation has 5 signs actually. Redness, known as rubor, swelling, known as tumor, heat, known as calor, pain, known as dolor, and loss of function because of the pain, the swelling, the redness, the heat, known as functional ACE, loss of function. And this inflammation is an alarming response, alertness response, in order to limit the spread of the pathogens. And it's going to rely on the cytokines. These cytokines are small proteins that regulate the inflammation and the immunity. So they are secreted mainly by the leukocyte, and they're going to alter the physiology of that receiving cell. So they act at short range. There's neighboring cells known as the hepatocrine, or these same cells that secrete them, known as the autocrines, and they may include the interferons. When do we see a high titer of interferon? When do you suspect when you see a lot of interferon? Interferons. We talked about that. Nope, not a parasite. That is xenophil. Interferons. Interferons are secreted by certain cells infected by. I mentioned to you that interferons are known hallmark that there's a viral infection. So why do we have heat and inflammation? Because of the hyperemia. So the hyperemia is a rush of the blood rush carrying these white blood cells into the site of the inflammation. Redness, because so much blood is rushing to the site of the infection. Swelling, because there is increased permeability, vascular permeability, to cause allow for the extravasation of these white blood cells through the endothelium into the nearby tissue to go and fight that tissue. Pain, that is from an indirect irritation of the nerve endings caused by the prostaglandins. So the neutrophils are going to migrate, and you have selectins. These are going to cause the leukocytes to adhere to the blood vessel wall. Then you're going to have diapedesis. These are leukocytes that squeeze between the endothelial cells into the tissue spaces. You see? You see now, this is the blood vessel. That's the tissue. And then you see that the neutrophils are going to come near the site that has sprinkled a lot of bacteria, a lot of antigens, a lot of cytokines. Then it's going to leak through the interendothelial holes, interendothelial gaps, to go out and combat and damage all of the bacteria and remove the necrotic tissue. Okay, so let's stop here to take our break, and we will continue at 2.
I think I got like, I'm just one, I guess. Yeah, no, definitely sarcastic. Like, I guess it's part-time, part-time, $20. Well, I don't know if I'm really lax, like, I could do something. Oh, what do you do?
I work on the clinic. We don't want to start it.
I think I'm on the same page right now.
I just need to start the last semester.
Oh. This is my third semester. This is yours.
Yeah, I was wondering, I'm wondering.
Well, apparently, everybody in your class, your critical section for critical, has to have everything set on passive range. And if they don't, then everybody can't go to critical, even if it's one person, it's not like it's for everybody. So with that being said, they put critical on right when that happens. So your clinical may be like, depending on how much long it is, you might fall online, you might be in person. So I would wait right here, and I think it's actually over.
Because I heard 4 semesters.
I'm pretty sure it's January.
And it's not.
So we have 2 more semesters. Well, technically 1 more semester because it's a one year. So after the semester, we have the one in September, and the semester after that will be clinical. I don't know how the clinical school is. $3 is really flexibility. And that's all.
It has to be. I have to make it more. Obviously.
Yeah. Meetings is a good part.
Sometimes it is. But she does it all the time. There's just a lot of information. I think those are questions.
Oh, yeah, I put some notes in.
Yeah, that's number.
I'm talking about. It popped up to me, like, senior knowledge. I was like, oh, yeah, like, I learned how to open my own languages. Like, now. No, because I never went. That's it.
Okay, so you can go, you go, but I'm just gonna say you were president till.
Yeah.
Okay, that's fine.
Thank you.
No problem. Okay, guys, so now we're going to examine the inflammation in more detail. So we said that inflammation is an alarming, alerting response. We don't get inflammation for no reason. There has to be a trigger. What are the triggers for inflammation? An infection, microbial infection, bacterial infection, parasitic infection, fungal infection, viral infection. Are infections the only trigger for inflammation? Are infections the only trigger for inflammation? No, trauma. See this piece of broken wood, broken glass, that causes trauma. So trauma is a cause of inflammation. Chemical burn, like when you spill a corrosive agent on your skin, that's gonna cause some abrasion to cause trauma. What about physical agent? It's too hot. What if it's too cold? That's gonna cause inflammation. What about temperature changes? It's too cold, too hot. That's gonna cause inflammation. So inflammation is a terminal state of alarm that your immune system must intervene immediately. And you see how it intervenes. You see, it's a response that requires the blood vessels to open up. You see these gaps? Who is moving through the gaps? The white blood cells. What are they headed to? They're headed to where all the sprinkles, these cytokines, this is known as chemotaxis. So the white blood cells are taxiing to the site of inflammation by responding to these chemicals. And we said the role of heparin is very important because it makes the blood thin. So the movement of the white blood cells is not impeded or occluded by this hypercoagulable state of many red blood cells. Neutrophils destroy and neutralize the bacteria through phagocytosis, swallowing, this bacteria. And then there's a respiratory burst. What's respiratory burst? Respiratory burst is a series of chemical reactions. These chemical reactions are going to convert a neutral substance into a superoxide, into a reactive oxidative species, and use it to kill the bacteria. So for example, in respiratory burst, we convert oxygen into superoxide dismutase. And superoxide dismutase is a negatively charged free radical. It's going to cause oxidative stress, and this oxidative stress is going to damage this bacteria that we engulfed and galloped and swallowed. This figure here shows you the lineage of the stem cells. So you see that we all have a multipotential hematopoietic stem cell that may have two destinies. One destiny is myeloid progenitor, the other one is lymphoid progenitor. So from the lymphoid progenitor, you will have the natural killer cells and your T lymphocytes and B lymphocytes. B lymphocytes eventually give you plasma cells, and these are the originators of the antibodies. That's really important. It's very important for you to appreciate that we have a one central multipotent, in this case bipotent. It has two potentials. One potential is to become myeloid, and the other potential is to become lymphoid. The lymphoid cells are your natural killer cells, or the small lymphocytes known as the T lymphocyte or the B lymphocytes. B lymphocytes are going to differentiate into plasma cells. These are the ones who make the Y-shaped antibody. That clear? On the other lineage, the myeloid progenitor, you have everything else. You have your red blood cells, you have your mast cells, you have the myeloblasts that are going to differentiate eventually to give you the basophil, the neutrophil, the eosinophil, and the monocytes. And we said monocytes evolve and they become macrophages. What are the megakaryocytes? Megakaryocytes give you your thrombocytes or the platelets, these band-aids that stick into the wound to prevent any blood loss. This figure is very important for you to be able to tell where do plasma cells come from, B lymphocytes. Where do lymphocytes come from? They come from lymphoid progenitor, while everything else comes from myeloid progenitor. You must remember that thrombocytes come from who? Megakaryocytes, and then macrophages come from the monocytes. Tissue cleanup and repair. So monocytes are the primary agents of the tissue cleanup and repair. They arrive 8 to 12 hours and become macrophages. They engulf and destroy the bacteria and the damaged host cells and the dead and the dying neutrophils. The edema contributes to the tissue cleanup. So this swelling compresses the veins and reduces the venous drainage. And the lymphatics are going to collect and remove the bacteria and the dead cells and the protein. What is pus? Pus is an accumulation of debris, and it is a yellow accumulation of dead neutrophils, cellular debris, bacteria, and toxic unwanted waste. So an abscess is an accumulation of pus in a tissue cavity. So the large amount of pus is going to lead to the formation of an abscess. What does the platelet-derived growth factor do? It's going to be responsible for causing endothelial cells to multiply and enter into the sprouting phase of making regeneration and making more red blood cells. And now we move into the adaptive immunity. So now we're not dealing with generalized, non-specific. We said there's cops, and cops deal indiscriminately with all different types of crimes: theft, assault, trespassing, check fraud. We deal with all of that. But once the problem gets more serious and more specialized, more specific. So that, in a sense, means adaptive immunity. If you have immunity against chickenpox, does not mean you will have immunity against measles, because it is a specific response. You adapt to a specific particular microbe, and you have specific memory cells to that particular measles virus, not the chickenpox. So this is the most important thing, is this element of memory, to remember. So your adaptive immune cells, they react, and then they get recruited. So first of all, they get recruited, then they react, and then they remember. So 3 R's, R. They get recruited to the site of the microbe, then they react, they neutralize, and they destroy this particular microbe, and lastly, they remember. They remember that microbe. So we have specificity and we have memory. And we will see how exactly that takes place. You must understand there are 2 types of immunity. There is cell-mediated, that is by T cell. So you have the actual cell fighting. Remember we said, how do they all kill? How do the B lymphocytes kill? How do the natural killer cells kill? And how do the B lymphocytes kill? We said B lymphocytes kill how? Yeah, good. So B, white chain antibody.
And the C,
cytotoxic?
yeah, some of the enzyme.
Yeah, good. And so there's 2 classes of enzymes that they rely on. There's the perforin, and the granzymes. Very good. And we said that the last type, the natural killer cell, they rely on swallowing, phagocytosis. You see, humoral, they rely on antibodies. And here they attack and destroy the cells. And it's called humoral because many of the antibodies are dissolved in the humor, in the fluids of the solution. Okay. The natural active immunity. So now that's important. That's really important. Let's now talk about that. You see, immunity, there's 2 kinds of immunity. There is passive immunity and there is active immunity. There is passive immunity and there is active immunity. each one of them is divided into two parts. Natural and artificial. Natural and artificial. That's immunity. That's really important. Is that clear? There is passive immunity, there is active immunity. So before we talk about natural and artificial, what's active immunity, what's passive immunity? Yeah.
Is that something like your active immunity, such as your immune system, like your body itself? That's it. Like externally.
Okay. So this is adaptive immunity. Because remember, we finished talking about the innate. Now we're talking about adaptive. So everything here is adaptive. That's why we began talking about the T cell, the B cell. So maybe I wasn't clear enough. This is all adaptive. So adaptive immunity is divided into active adaptive immunity and active passive immunity. So what does that mean? Okay. Active means it was stimulated. It was the antibodies and the T cells and the natural killer cells, the ones that throw the Y shape, the B lymphocytes and the T lymphocytes, the cytotoxic, and also the natural killer cells. Those were stimulated. They are active, meaning something caused them to be generated by your body. So if it's natural, that means you got infected. You got infected. You got some viral attack. You got some viral attack. You got some bacteria. You got some parasite. You got some fungi. You got some fungi. You got some microbe that attack your body, and your body naturally made T cell, B cell, and all of these phagocytes. Naturally stimulated. But point is, active means stimulated. Your body made them because of stimulation. Here, it was a natural infection. Now, what is artificial is when you get immunization. So here, we give you an injection of some virus or some bacteria that is attenuated, heat-killed, that cannot hurt you, but can elicit an immune response. So here you will have T cell, you will have B cell, but they are responding to some artificial attack. But in the end of the day, it's an attack. This one is a natural attack. You got sick. This one, we give you an injection, but bottom line, your body made them in response to a stimulation. Is that point clear? In passive immunity, you were not stimulated. You were given a gift, like a mom giving her baby in the placenta. Natural, like a vertical passage from a mom to her baby through the placenta. She gives antibodies. So here, no stimulation. Here, you would give him free antibodies from your mom, or breast milk, through the mom. Breast milk, mom give you antibodies through breast milk. Mom give you antibody through placenta. Before you are born, mom give you antibodies in the placenta. After you are born, she continues to give you a strong immunity after with the breast milk. But when you stimulated, you're no stimulation. What's artificial? It's like when you have some disease, then they take somebody else's antibody or they take it from an animal like a horse. You know, they do that. They go to a horse or somebody else donating their antibody for you, then they give it to you. So now it's passive, but it's not natural from your mom. It is artificial. They made it in a lab with somebody else, but based on somebody else's stimulation. That is really important. Knowing what's active immunity, what's passive immunity, what's an example of natural active immunity, what's artificial active, what's natural passive, what's artificial passive. Clear? Yeah, artificial passive. Artificial passive. When you take somebody else's antibody, or from a horse, or from some animal, it happens too. It's easier. Okay, so natural active immunity, production of one's own antibodies. So you make them. Artificial active is you make them, but based on a vaccine. Passive immunity, you never made them. You were passive. You were given free for you. There's the natural passive immunity, and then there's the artificial passive immunity. The antigen is any molecule that triggers an immune response. We talked about that. What's an epitope? What's an epitope? An epitope is a mini antigen. It's not big enough to elicit a response, but we have to add some stuff to it, then it will elicit the response. The epitope. A certain region of an antigen molecule that stimulates the immune response. On its own, it cannot generate a response, but you have to add some stuff to it, then it can generate a response. And that's what we use for the vaccine. So we take those weakly attenuated microbes. Haptens are too small to be antigenic themselves. They can trigger. So the epitope is part of the antigen. And the hapten can trigger an immune response by combining with the host macromolecule. Now, these antibodies are also known as immunoglobulin. Same thing, tomato, tomato. Antibody is an immunoglobulin, and we have different ones. We have immunoglobulin A, immunoglobulin G, immunoglobulin D, immunoglobulin E, immunoglobulin M. A for alpha, B for beta, G for gamma, D for delta, and M for Mida? Mu. Mu. M for mu. Okay. So this is the anti-Y shape. You see the Y-shaped antibody. As the Y-shaped antibody, it has the heavy chain, and these are the light chains. The immunoglobulin G antibodies account for 80% of all the antibodies. Immunoglobulin G antibodies are responsible for resistance against many viruses. Immunoglobulin E attaches as an individual molecule to the exposed surface of the basophils, and that's immunoglobulin D is an individual molecule on the surface of the B cells where it can bind antigens, and that's immunoglobulin M. There's something very important you need to know about immunoglobulin M. That's the one that works when we agglutinate, when there's agglutination. When remember last week when we said if you put an anti-A serum sample and you put a blood type on it, it's going to agglutinate because an antibody is going to glue them up, agglutinate them. That's IgM, immunoglobulin M. Immunoglobulin A, that's the one that's going to be in the mucus. So you need to know that. You need to know each immunoglobulin is known for what. Immunoglobulin M, that's the one for the agglutination. Immunoglobulin A is found in the fluids like the mucus, the semen, and the saliva. Immunoglobulin E is for the allergy. That's the easiest one to remember. E for allergy. Immunoglobulin E is found on the surface of the basophils and the mast cell. Immunoglobulin D is an individual molecule on the surface of the B cell. It binds to antigen on the extracellular fluid, and it plays a role in the sensitization of the B. And the immunoglobulin G is responsible for all the activity against viruses. So you have to understand that when you first get an attack, you get a primary response. You just got attacked by a microbe. So when your immune system responds to that, that's known as primary. Then when you form memory cells and then you get a second infection, that's the secondary attack. So the primary attack is always going to be through the immunoglobulin M. And the secondary is by immunoglobulin G. So if you take a blood sample and you see there's too much immunoglobulin G, you know that the secondary, this is the second time that this patient has been attacked by this virus. That shows you. Immunoglobulin A found in the mucus, the milk. Immunoglobulin D is a B cell transmembrane antigen receptor. E is for allergy, stimulus histamine, and it's used for allergy. Immunoglobulin G, 80% of the circulating antibodies. It is secreted in the secondary attack. Remember, primary and secondary? So the immunoglobulin G represents the secondary. And immunoglobulin M is the one that is in the primary response. This is the site where we mature as B cells, and that's where we mature as T cells, and then we go to the lymph nodes and in the spleen and the tonsils, and we reside there after we get deployed. We get deployed here. But we graduate in a thymus or we graduate in a bone marrow. 3 stages: born in the bone marrow, educated or trained in the thymus, deployed to carry the immune function in the lymph node and the tonsils. T cells cannot recognize antigens on their own. So we need antigen presenting cells. There's something very important for you to understand is that antigen presenting cells depend on MHCs, major histocompatibility complexes. These major histocompatibility complexes. These are the complex proteins that we recognize. These are the identification tags. And there is two types. There's MHC1 and MHC2. Major histocompatibility 1 and major histocompatibility 2. MHC1 and MHC2. You will see that your helper T cells bind only to MHC2, while your cytotoxic T cells bind to major histocompatibility complex 1. So there we go. What's green here? That's the microbe. We internalize. Then we fuse a lysosome. You see the lysosome fusing with the phagosome. You have a phagolysosome. Then we take a fragment and we present it up. You see what I was saying earlier? Taking a fragment, presenting it outside. What do we present it as? As an epitope on an MHC complex. So the MHC protein is what we recognize as a factor to tell that this cell must be damaged. Now the T cells are 4 types: cytotoxic T cells, helper T cells. These are the most important two. Regulatory and memory T cells. Memory T cells, you know, the same way we have memory B cells, we have memory T cells. Cytotoxic and helper T cells cooperate to destroy the microbes. So the cytotoxic T cells, they bind to CD8 proteins, while helper T cells bind to CD4. It's very important to tell which of the cells bind to which type of proteins. There is the cytotoxic, the CD8 that binds to cytotoxic T cells, while helper T cells bind to CD4. So the aspects of the recognition in the cellular immunity, you have the antigen presentation and the T cell activation. So when the antigen present, remember we discussed that the antigen, these APCs, the antigen presenting cells are going to encounter and process the antigen, and then they're going to hold it up in order for the helper T cells and the cytotoxic T cells to detect it. Then the T cell and the cytotoxic T cell and the helper T cell are going to bind to the MHC protein. We said there is how many types of MHC protein? How many types do we say of MHC protein do we have? 2. We have MHC class 1 and MHC class 2. The cytotoxic T cells bind to MHC class 1, while the helper T cells bind to MHC class 2. That's very important to remember. Cytotoxic T cells bind to MHC class 1, and helper T cells bind to MHC class 2. Then that's going to lead to successful stimulation that will trigger the T cell to activate. This figure is very, very, very important. What do you see here? This big cell is the antigen presenting cell. That's the cell that's presenting, you see this yellow antigen? This yellow antigen is a fragment, a piece of this bacteria that the antigen presenting cell swallow. So you know the antigen presenting cell is the first line. It will go and it will gallop and swallow bacteria, parasites, viruses, fungi. Then the antigen presenting cell is going to snatch and fragment and grab a piece of the antigen presented on the outside. Once it's presented on the outside, it's going to present it through an MHC complex. This MHC complex is going to be recognized by the cytotoxic T cell or the helper T cell, depending on what type of MHC complex are we dealing with. If it's MHC complex type 1, who's going to recognize that? MHC, major histocompatibility complex type 1. Who recognizes that? Cytotoxic T cells, CT. While the MHC2, major histocompatibility factor type 2, who recognizes that? That's the helper T cell. And then there is a co-stimulatory protein, that orange one. That one is very important because that's like a verification. We verify that yes, this cell needs to be destroyed. And you see the cytotoxic T cell is going to bind it. And if it was a major histocompatibility complex type 2, is going to bind to the helper T cell. And then all of them, after the binding of the T cell to the major histocompatibility complex and the co-stimulatory protein, what's going to happen now is there's going to be a co-stimulation, and then there's going to be a proliferation, a differentiation of the involved T cell, whether the T cell that is cytotoxic or T cell that is helper T cell. And then they're going to differentiate into two classes of T cells. Either cytotoxic T cells, helper T cells, or memory T cells. And then you're going to have the ultimate effect. Helper T cells lead to destruction by stimulating by stimulating the activity of natural killer cells, B cells, and recruiting other cytotoxic T cells. But the T cell on its own is going to put those perforation enzymes and granzymes. So the point here is that it's the MHC protein that is the one that is going to tell me who's going to bind to the antigen presenting cell, the APC, and what is the fate of that T cell. Is it going to differentiate into a cytotoxic T cell or a helper T cell? And then definitely we will have some memory T cells that are going to be on the side. It's your MHC complex that's going to tell. MHC1 will recruit cytotoxic T cell. MHC2 is going to recruit helper T cells. So the helper T cells play a central role in coordinating both cellular and humoral immunity. And you see that the helper T cell is going to kill by 3 ways with a macrophage activating factor, interleukin, and other cytokines, and that's going to lead to humoral immunity. Okay, there's the destruction of a cancer cell by cytotoxic T cell. And there's always going to be, whether we're dealing with cytotoxic T cell or helper T cell, in the end of the day, this is a adaptive immunity. So we will always have memory T cells. If you look at the B cells, we're going to send antibodies that are going to bind to the antigens and tag them for destruction by other means. And these B lymphocytes, we said, are going to differentiate into plasma cells. And the plasma cells are going to give us what? The plasma cells are going to give us, what will the plasma cells give us? I'm sorry? The B lymphocytes give us plasma cells. And plasma cells give us, I showed you that in the figure. They give us the antibodies, right? So if you look into this figure, we said that the B lymphocytes give us plasma cells, and plasma cells give us the antibodies. So the plasma cells ultimately give us the antibodies. So the B lymphocytes produce antibodies that bind to antigens and tag them for destruction by other means. So most of the B cells, B lymphocytes differentiate into plasma cells, and we said there is a primary attack that involves the immunoglobulin M. And then there's a secondary attack that's going to later cause an exposure to the same antigen, and that's going to be known as immunoglobulin G. Immunoglobulin G. So that shows you here, just like what we had with the cytotoxic T cells. You see, the same way we dealt with the cytotoxic T cell, you're gonna have a B cell presenting a MHC2. So since we're dealing with MHC2, what kind of T cell are we dealing with? That's a helper T cell. Then there's gonna be two lineages of differentiation. One is going to give you the plasma cell that will secrete the Y-shaped antibodies, and then it's going to be memory B cells. Same way we had memory T cells, we're going to have memory B cells. And we destroy not only by amino acid, by the antibodies, we have neutralization and complement system activation, agglutination, precipitation, but it's the beginning. How we elicit this immune response, that's what's going to lead to the destruction of the that's what's going to lead to the destruction. We said which immunoglobulin is involved in the agglutination in the blood. That's immunoglobulin M. It's very important to remember. So the primary immune response is going to involve which immunoglobulin? M. So immunoglobulin M is going to be, there you go. You see in the beginning, immunoglobulin M is going to rise. 15 days later, then immunoglobulin G is going to be the secondary response. But if you get reinfected again, who will spike now? It will be immunoglobulin G. That's very important to remember, that the predominant immunoglobulin in the primary response is the immunoglobulin M. You see, the x-axis represents the days from the exposure. So you got exposed, up to 5 days later, the immunoglobulin M is the one that's predominant. Then after that, immunoglobulin G develops. But if you get re-exposure, who remembers and comes back out again? That's your immunoglobulin G. Now, these are the diseases. We alluded to them. We said that we are concerned with our immune system being too aggressive, hypersensitive, or less aggressive, hyposensitive, and making a problem of being hypersensitive in the wrong place, having amnesia. So when the immune system has amnesia, no longer remembers self from non-self, that's gonna cause destruction of the own bodily tissues. Hypersensitivity is an excessive immune reaction against some antigen. Alloimmunity is when there's a reaction to a transplanted tissue from somebody else. Autoimmunity is amnesia. Allergies is over-exacerbated immune reaction to an allergen, like a dust, mold, pollen, or a vaccine. There are different types. There's hypersensitivity type 1, that's known as immediate hypersensitivity, and you can always distinguish all these hypersensitivity types based on the onset. One is very rapid, And 2 and 3, they are from about 3 hours of exposure and above, and they last up to 15 hours. Then the last type is type 4. That's the delayed cell-mediated response that involves a complex. So type 1 is mediated by immunoglobulin E. That's why we consider asthma as a type 1 hypersensitivity reaction. And we are worried with the hypersensitivity. We discussed this in the past when we were saying septic shock and hypovolemic shock and anaphylactic shock. All of them are, in the end of the day, shock. Whether it's anaphylactic shock, cardiogenic shock, neurogenic shock, septic shock, anaphylactic shock. In the end, a shock is a shock. And a shock means what happens to the blood pressure? It goes up or down? Drops. Why? We said because the blood vessels dilate. Why are the blood vessels dilating? Because they want to get the blood to the right place with the white blood cells, because there's an inflammation, there's some problem. And we discussed in the past that the more you increase the diameter of the blood vessel, what happens to the cardiac output? Goes down. So in this anaphylactic shock, some pollen or some pet dander or something like that causes you to have allergies, and there's a continuous vasodilation in your body to recruit these white blood cells, and that keeps on dropping and dropping the cardiac output, and your body is not getting enough blood, and then that leads to death. Okay, that's the asthma, and we said the treatment of asthma is epinephrine. Epinephrine is a fight or flight hormone. It constricts the blood vessels, but it vasodilates the airways. It constricts blood vessels and it vasodilates the airways. Type 2 occurs when immunoglobulin G or immunoglobulin M attack antigens that are bound to the cell surfaces. Example of that. So you have to know what are the examples of immune hypersensitivity type 1, like the asthma. Hypersensitivity type 2, example of that is going to be blood transfusion, pemphigus vulgaris, that's the acne, and some other drug reactions. Type 3 is when immunoglobulin G and immunoglobulin M form a complex that's going to precipitate against the endothelium. Example would be the autoimmune diseases like the acute glomerulonephritis and systemic lupus. Lastly, you have the cell-mediated reaction, in which the signs appear later, and it begins when the antigen-presenting cell in the lymph node display these antigens to the helper T cells, and that's going to cause excessive interferon and cytokine secretion. Example of that would be haptens in the cosmetics, poison ivy, graft rejection, tuberculosis, skin test, and diabetes mellitus. Then the opposite of hypersensitivity or hyperimmune reaction is the opposite, hypoimmunity. And an example of that is severe combined immunodeficiency, meaning it's a recessive disease where the immunity is going to drop, and now the patient is susceptible to death from any easy disease. They have to live in a bubble. You know who's this? This is David Vedder. This is a child that was born in 1971 and lived until the last day of his life inside this plastic bubble made by NASA and his hospital to protect and ensure that he doesn't get an infection, a bacterial infection. And in the end, they decided he lived 12 years inside this bubble. And they decided that this child, let's transplant bone marrow. Why were they trying to transplant bone marrow? Because you know the bone marrow is where the blood cells are made, the white blood cells. So they wanted to make white blood cells for him. And it turned out that by mistake, his sister who donated the blood, she had a virus hidden in cell, and then the boy died. I'm going to show you a video of him in a little bit. And then you have the HIV virus, where David Vetter, he was born with a genetic disease. He cannot make white blood cells. But here, somebody that had white blood cell in the beginning, in the white blood cells, you had you had an infection with the retrovirus and RNA. This is the HIV virus. It's an RNA virus that has a reverse transcriptase. Reverse transcriptase can go backward and create DNA from RNA. That's why they call it reverse transcriptase. And the diagnosis is when you have less than 200 cells. This is very important. How do you tell somebody has AIDS? Is when they have less than 200 white blood cells per microliter. And then cancer that is known that people with HIV have is known as Kaposi sarcoma. And the most common mode of transmission is sexual intercourse, contaminated blood product, contaminated needles, and so I want to just end with the David Vetter story. It's very important that, you know, I don't know. I think they did. I'm not sure. I think you're right. Maybe they did. That's him.
Safely live. Our health reporter Haley Hernandez spoke with his mother today to discuss a very important anniversary. She joins us now with a story that you will see only on Tube. Haley?
Yes, so tomorrow would actually be David Vetter's 50th birthday. Now, in medicine, this gives an exact date on when you can look back and say, this is exactly how far we've come treating kids who are immune compromised. It's a very special time for his mother, who set out 50 years ago to make David's life meaningful, and she succeeded.
David's contribution to science was dramatic, and I'm proud to have shared in David's life.
Carol Ann Demerit is the mother of David Vetter and an advocate for families and babies affected by immune disorders. When her son was born in 1971, he was so immunocompromised that he lived in a sterile bubble designed by Texas Children's Hospital and NASA. Back then, the only way to keep him alive was to always keep him away from germs, and it began at his birth.
I had watched as one doctor baptized David, which was my only request, and the other doctor sealed the bubble.
He died in 1984 at age 12, but today the David Center at Texas Children's saves many lives because of what they learned throughout David's time as a patient. In this never-before-seen video provided by Texas Children's, you can see David engaging in activities like most kids, playing with blocks, learning to read and write, and his mother says he had an idea that he was contributing to science, but nobody could have imagined how huge that contribution would be.
We began to understand things about the immune system impacted not only children with primary immunodeficiency and adults with primary immunodeficiency, but people with AIDS, cancer, and other immune diseases.
So while the loss of a child never goes away, the victories in science give David's family a reason to celebrate every day, especially on his birthday.
I think it's important that people not feel sorry for David or for his family, because there was a lot of joy in raising David.
Now, one of the more recent breakthroughs as a result of David's life is newborn screening that can detect immune diseases. Dr. David says there's currently over 400 immunodeficiency diseases that can be treated before patients develop an infection, which can be life-threatening. Many are treated with bone marrow transplantation, another breakthrough in science for which David was their first patient. Guys.
You okay? Everybody's loving that grub up here with Prime, huh?
Should we just stop? Amazon Prime Group?